Dear viewers, welcome to my YouTube channel, medical channel by Dr. Bishay. My name is Bishay. I'm a board-certified internist practicing in the United States for the last 25 years. It's my honor to present Outpatient Clinic, which is a medical program meant solely for information and education to all of you, dear viewers. This program is not a treatment program, absolutely should not be taken as a treatment. However, it's just meant for information and education. You should keep your family physician and primary care physician to treat you and do whatever investigation you needed. The first episode is called Acute Myocardial Infarction or Coronary Artery Disease, and particularly I'm very interested in presenting what we call widowmaker, an artery in the heart, one of the coronary arteries called LAD. That particular artery, if it gets blocked, if you have a severe heart attack in that artery, it can cause severe damage to the heart and can cause sudden death. For that reason, I want to educate everyone, warn everyone and about that artery, and typically about coronary artery disease and myocardial infarctions or heart attacks. So we have two types of angina. One is chronic stable angina, or chest pain that occurs with exertion, typically relieved with rest, does not occur every day. It can be relieved with nitroglycerin and is not very severe. The other type is called unstable angina, whether acute or chronic. This unstable angina is a type of chest pain that occurs at rest and occurs with increased frequency, intensity, duration, and it might not get relieved with nitroglycerin, and that serious type, you may need to go to the emergency room, seek medical advice right away, because this could be a sign of acute myocardial infarction or a heart attack. There's two types of heart attacks. One is called non-STEMI, non-ST elevation myocardial infarction, no ST elevation on the EKG, and there is another type. We diagnose that type, by the way, with typical history and with the heart enzymes, troponin I being elevated. The other type is called acute ST elevation myocardial infarction. That's more serious. We see signs of ongoing damage to the heart with acute heart attack and ST elevation on the EKG. The risk factors for coronary disease include advanced age. Male sex tends to get more than female until female reach the postmenopausal era. Men and women are equal in incidence if the women are postmenopausal. In other words, women under the menopause, younger women, tends to get some protection with estrogen hormone, but postmenopausal women could have almost the same incidence as men. First degree relative coronary artery disease constitute a risk factor, definitely, or a previous coronary disease or a previous stent in you could be a very high risk factor that you're still ongoing pathology, still ongoing process, causing more insufficiency or coronary blockage, other coronaries. Smoking is a big risk factor. Hypertension, diabetes, hyperlipidemia, and obesity is a big risk factors. Symptoms, chest pain, we ask about duration, intensity, radiation. Could be radiated to the left shoulder, typically. Could be radiated to the back, to the jaw, to the neck. You could have epigastric pain, chest pain, kind of top part of the stomach. You could present with nausea, vomiting, dry heaves, vague symptoms. Because the right coronary supplies the posterior wall and the inferior wall of the heart, so you could get similar symptoms like the stomach symptoms. Sort of gastric upset. You could have chest pain on the right. Some people tend to have right-sided myocardial infarction. You could have chest pain radiated to the shoulder on the right side too. The bottom line, every chest pain is serious enough that you take it serious, seek medical advice right away. We tell patients that know that have chronic stable angina, take a nitroglycerin under the tongue, 0.4 milligram under the tongue. If it doesn't take the chest pain away, take another one in 5 minutes. If it doesn't go away in another 5 minutes, take a third one and call 911, please. Go to the nearest emergency room. Coronary disease can present with shortness of breath or exacerbation of a heart failure. It does not mean that every time you're going to have chest pain. It could present in some patients with just shortness of breath. Some people may just have fatigue, or they cannot do their exercise as usual, cannot walk many blocks on the road. So these are all symptoms that you have some coronary insufficiency. We diagnose it by history, physical exam, some blood tests, including troponin I or CPK, but the troponin I is more sensitive. Every ER has that test. We look at the EKG. We do stress tests in the clinic or inpatient sometimes. There are two types of stress tests. One is exercise tolerance test, treadmill test, physiologic. You go on a treadmill. We look at the EKG and monitoring your heart rate and rhythm and see if you get symptoms while you're on a treadmill. And we increase the speed of the treadmill and we increase the incline slowly and we see how you're doing. The other test is stress echo. An echo with a stress with some exercise and we check the echo. The other test, which I like a lot, is called stress test with nuclear medicine. We call it Lexiscan or stress my view test. In some cases, we call it adenosine or dobutamine stress test. In some particular patients with asthma cannot take the usual dye, if you will, that we use. So when we do that test, we get all kind of images and we see if there's any sort of blockage. That test is about 85 to 90% sensitive. In some cases 95%, but it's not 100% sensitive. After that, there is a CT coronary angiogram. It's a pretty sensitive test as well. It's a CAT scan. Looks at the calcification around the arteries and kind of give us a clue if there is calcification in some of the coronary arteries. The final test, which I like a lot, very sensitive test, is called coronary angiogram, cardiac catheterization. The cardiologist or interventional cardiologist goes through the radial artery or the femoral artery on the thigh and go with the contrast dye, picture the whole tree, if you will, of the coronaries. It starts with the left main, the big one, that split into right coronary and left coronary. The one I'm very concerned about is LAD, left descending artery, and that gets another branch called circumflex. We will see that, but just kind of give you a clue about the anatomy and the tree that God created in us, with the left main being the main artery. And that typically, if you get a heart attack, blockage in the left main, it can cause sudden death. If you get a heart attack severe enough in the LAD, left descending artery, and there's complete blockage or a severe coronary spasm of that artery with a blockage or a big clot, it can cause sudden death. That's why we call it widowmaker. The treatment, first you control diabetes, hypertension, and cholesterol. You stop smoking. You weight loss with or without gastric bypass or gastric sleeve. We typically tell people to eat healthy, use diet, use exercise first. In morbidly obese, certain cases with diabetes and high risk factors, we refer them for a bariatric surgeon to look at them and evaluate for gastric bypass. We give aspirin, 81 milligram. We're in the ER. Some patients are on aspirin and some other blood thinners, which I will get to if they have a stent, daily. We give nitroglycerin with a short acting under the tongue, 0.4 milligram, like I said. Or we give Mdor, long acting nitrates. It could be 30 milligrams, 60, or in some cases 90. We give a group of medicine called beta blockers. You're probably familiar, heard the word metoprolol, metoprolol tartrate, metoprolol succinate. Metoprolol could be given as a long-acting, 25 milligram a day, and can go up to 50, 75, or 100. Or it can be short-acting, given 25 twice a day, or whatnot. The doctor can go up on the dose as needed. We give a group of medicine called statin. You heard this word, atorvastatin, simvastatin, or Crestor. Crestor I like a lot. It's very strong. You can start with 5 or 10 or 20, even 40 in some cases. Lipitor, you start with 10, 20, or 40, or even 80. Simvastatin, 10, 20, or 40. Your doctor needs to check your liver enzymes, and in some cases you get transaminases, liver enzymes goes up, then he has to stop the medicine and follow them. You need the LDL and the fasting lipid panel, check the whole cholesterol, the total, the HDL, the good cholesterol, the LDL, the bad cholesterol. In cases of heart attack or coronary disease or diabetes, we like the LDL very strict. We like it less than 70. In people with no much risk factors, we kind of tend to like it less than 130 or less than 100. Every year we get new guidelines and we're getting more stricter and stricter on the cholesterol. There is a new medication, not very new, but something called Repatha. It's a subcutaneous injection you take every 2 weeks in the belly fat and subcutaneous tissue in the abdomen, 140 milligram every injection twice a month, and that can be given, and it lowers the bad cholesterol, can go from 130 all the way down to 30. It's like magic. The bad thing, it's very expensive, and your insurance has to deal with that. Some of these injections can cost $500 a month or even $800 a month. You can ask your pharmacy for a coupon or ask your doctors to evaluate if you need it. In some people, coronary spasm, we give some group of families of drugs called calcium channel blocker, something called Norvasc or amlodipine, 5 or 10 milligram a day. Some patients, especially with heart failure, need a group of drugs called ACE inhibitors, such as lisinopril, monopril, or a group of other medication called angiotensin receptor blocker. And these are good for the heart, for the ventricles. The bad side effects, it can affect the kidney function, or it can, even though it can protect the kidneys actually in people with diabetes, but it can worsen some people with kidney functions already have damaged kidneys, and in some cases it can cause chronic cough, and that incidence your cardiologist could change this medication. The other modality is you go and have a stent if needed. You do coronary angiogram for diagnosis first, and while you're there, your intervention cardiologist can put in 1 or 2 or 3 stents, depends on how many stents you need. Now, people with severe coronary artery disease, multiple vessel disease, 3 or 4 or 5 blockages, and people with left main, the big one is blocked, we tend to refer them cardiothoracic surgeon for open heart surgery or coronary artery graft. So something called CABG surgery. These typically done by experienced surgeon that takes some veins from your legs and put them in the heart. This is a long surgery, but it's a very good surgery for people with multi-vessel disease, younger folks with diabetes, but it has certain evaluation to be done. People that got a stent, they need aspirin plus another medicine. Could be Plavix, 75 milligram a day, or Berlanta, 90 milligram twice a day, which is a very strong medication, or Efient, 10 milligram daily. Berlanta is the one I favor a lot, but it can cause shortness of breath. This is a picture of the heart. The big one is the aorta. It brings the arteries, which is the coronary arteries. One goes to the left, LAD. One goes to the right, right coronary. This is the normal artery, a good wall, good lumen. All this, the artery is going, the blood is going there, and we have no problem getting the blood in there. It's quite wide. This is a damaged artery from diabetes and cholesterol. All the yellow is atherosclerosis. So typically you tend to see abnormal blood flow, stricture, blockage, and you don't get enough blood, and that's why you get the angina or chest pain, because the heart is not getting enough blood supply. This is another slide with a lot of damage to the lumen or endothelial wall of the artery, and it gets full of atherosclerosis, plaques. As you see, all this yellow is cholesterol and tends to have calcification, and this is the start of coronary disease. And the wall can rupture, and this cause a clot here, and the plaque gets ruptured, goes in the bloodstream and cause blockage to certain arteries, which cause heart attack. Typical chest pain, and you can see the plaques here are rupturing, and the platelets come and gather here and cause a clot. And you can see there's a lot of yellow from atherosclerosis. This patient's heart is really full of atherosclerosis. This is not it's just a photo from the internet. This is not a true patient. This is another slide, shows you all this atherosclerosis, all this yellow from obesity, hypertension, diabetes, and cholesterol, particularly high cholesterol and diabetes that damage the endothelium lining of the artery and cause damage to the endothelium, cause damage to the wall, makes the cholesterol plaques pile up here and cause damage. This is the ST elevation which I'm talking about. This is not the normal. You see this ST elevation here in the EKG in certain leads, and that kind of gives us a clue that this patient is having a heart attack. This is a plaque. And this is a stable plaque, but this is a rupture. The plaque is ruptured. This is a stable part of the wall. This endothelium ruptured causes an entry for this plaque, and then the platelets come here and cause a clot and pile up and make this clot bigger and bigger and cause stricture and closure of the artery and cause sudden heart attack. This slide is nice. It tells you stop smoking, control your cholesterol, eat healthy, do exercise, and reduce stress, and lower your blood pressure and blood sugar. Again, the chest pain, you see this part is already died from the heart and the left ventricle from a myocardial infarction. The chest pain can be severe, can be radiated to the left shoulder. Patient could have headache, shortness of breath, nausea, indigestion, sweating, vomiting, stomach pain, upper back pain, even jaw pain, depending which artery got blocked. This is the left main artery, and it kind of split into left anterior descending artery and the right coronary artery. So there is a right artery and the left artery. It goes left anterior descending artery. This is the big artery, big branch. It supplies the whole left ventricle. If you block this artery and you have a big blockage or complete blockage, it can cause sudden death. And that's why we call it the widowmaker. This is very crucial. You go right away to the ER and get a stent right away if needed. And another branch called circumflex, it kind of wind around to go to the posterior aspect of the heart and supplies the back of the heart and the left side as well. Again, this is the left main, this is the left circumflex, this is the left descending artery, and this left circumflex, and the circumflex gets a branch called left marginal artery. This is the right artery, right coronary artery, and the right coronary artery supplies the inferior vena cava and supplies the inferior wall of the heart from a branch. And this is the distal branch of the posterior diagonal artery, is the continuation of the LAD, left descending artery. So this is the last slide. To summarize, you have to take care of every and each chest pain that you get. Talk to your doctor, reduce stress, eat healthy, work on your weight, work on your diabetes, work on your blood pressure, work on your cholesterol. Prophylaxis is better than treatment, it's very crucial. If you do have a heart disease, start treatment right away, start diagnosis. You may end up needing a stent, but do whatever it takes. There's a lot of modalities of treatment, but we do not want to be late in seeking medical advice, and certainly we don't want to have, God forbid, sudden deaths. With my best wishes to all of you, my dear viewers, and I'll see you in next episode of Outpatient Clinic. Thank you for watching.